And in 1993, there was only one robotic type device being used in the surgical arena. And that device was called ASOP, and there were variations on ASOP that have come since then. But ASOP basically was a handheld camera so that you could get rid of that second assistant in straightforward laparoscopic surgery. The insurance company doesn't pay for a second assistant typically, especially for those types of surgeries that were being done laparoscopically. And so this was a neat way to get rid of the second assistant and to have a voice command robotic arm camera to tell it where to go when you wanted it to go, right or left, up or down. And that's what ASOP did for us. It actually is still in use today. There are many institutions that still use the ASOP for their laparoscopic techniques. Well, with this flare of minimally invasive surgery, the Department of Defense came up with a project idea, and they brought it to the Stanford University. And their idea was to someday have this telesurgery that would be available for the soldiers on the field. That you can get a soldier on the field into a MASH unit and have an expert surgeon off in a safe place, on the ship if you will, in order to perform this telesurgery, this telescopic digital type of surgery. In the middle of that project, they developed this type of robotic surgery that I'm going to show you. This type of robotic surgery I'm going to show you is still very much cable dependent. It's not digitalized yet. In fact, the room is loaded up with a lot of cables. And that's exactly how this company was started. Some engineers broke out of that project and started their own company. And they got FDA approval in 1999. Basically, robotic surgery is just like laparoscopic surgery. It's minimally invasive. It's done through small ports. But instead of a two-dimensional camera, we're using a three-dimensional camera. So that gives us depth perception. It looks just like our own eye view. It's 10x magnified at all times, and the newest machine has a 5x amplification of that. And the greatest thing about it is the instrumentation. When we show you the surgical videos, you'll see it has 360-degree articulation at the joint. And so it works even better than our own hand. It allows us to be coordinated through all 360 degrees as opposed to our own hands where we're not quite as coordinated throughout all 360 degrees. This is what one of the newer models actually looks like. This is where the surgeon would sit after the surgeon places these little metal ports in the patient and then snaps on these robotic arms and places the instruments of use for that particular surgery, as well as the camera. So all of this would be inside the patient's body cavity. The surgeon would then take off their sterile gown, take off their sterile gloves, and go and sit here. This is a very convenient, sophisticated module. It raises and shortens depending on the surgeon's height. We'll give you an up-close view of these hand controls. Are very ergonomic, and if you come out on Saturday, we'll show you just how easy they are to use. It's kind of like playing the piano, because while you're using your hands here, your feet are at work with certain clutch buttons and controls to use electric cautery while you're using the instrument. You'll see in some of the surgical videos, we're actually cauterizing while we're cutting. And grasping and cauterizing at the same time. Those controls are based at our feet. Basically, robotic surgery has brought to the laparoscopic field all of these benefits. It's very much improved precision. The increased range of motion is phenomenal. The increase in dexterity is even beyond what your own hand can do. The enhanced visualization is very consistent. You've seen surgeons wear telescopic lenses. Those are very hard to get used to, and actually they're not consistent as you look around your view. The robotic instrument allows that 10x magnification to be very consistent And it helps us to get into areas that we couldn't get into before laparoscopically. Well, here's where we were in 1999. There were two intuitive built robotic instruments, just like the ones I showed you. There we are up to 2001. That's how many have been sold up to 2002, up through 2005, and all the way up through 2008. This is just to show you that this is not new technology. It's now approaching being 10 years old, and it's ever changing. They're likely just ready to come out with even a new model. But the growth throughout the United States, let alone the world, I didn't put the world map on here, has been phenomenal for the company. This is what a typical OR room setup looks like, with, again, the surgeon over here. It's very much cable dependent to a tower that then connects this patient cart in a very sophisticated way. We'll show you a more up-close view. This is, again, the device that attaches to the patient. These little metal ports are what go inside the patient. Those instruments that we use, the scissors, the graspers, the needle drivers, they make many different types of instrumentation. Those are popped in and out very quickly by your bedside nurse or surgical assistant. They just snap right out. If you want a scissor or 2 needle drivers, it's just real quick. You say, you know, you needle driver in arm number 1. I wanted to show you this brief video by the company because it gives you a good idea of how this works. I'm going to talk a little bit over the audio because you don't need to hear that. So the patient would be obviously lying over here. The surgeon's very comfortable over here, usually freezing to death, sitting underneath the air conditioner. The ORs are kept very cold, so I actually usually wear a warming jacket because it's freezing without our surgical gear on. We're working our hands exactly as we would be moving them in open surgery. The movements are identical.
The surgeon's hand movements are scaled, filtered, and seamlessly translated into precise movements of the endo-wrist instruments. The net result is an intuitive interface, enabling unparalleled precision, dexterity, and control.
So this type of technology is actually unsurpassed by anything that we've ever seen in the surgical field previous to 1999. These hand controls are very, very comfortable. Again, if you come out on Saturday, you'll be able to see we have rubber bands and cones set up where a patient would be typically lying, and you can pick up the rubber bands and shoot them and place them, and you'll be wanting to do surgery after you come over. The articulation at the wrist of the instrument, again, not only mimics your wrist, but it gives you far more dexterity than your own hand. Again, when I'm twisted like this robotically, that instrument is right on. Whereas if I was using my own hand, I would have some discoordination being upside down with my hand. So obviously, this far surpasses any of the laparoscopic conventional instrumentation. It's like night and day. This is how small these instruments are. They're very tiny. They come in on a stick, if you will, that create a small incision and very easy for the patient to heal from. There is one of those ports will be used to remove the organ. Unless you're having gynecological surgery, they oftentimes can remove things through the vaginal area, so then you wouldn't have an enlarged port site. But say when we're doing prostate or bladder cancer surgery or kidney cancer surgery, we have to incise one of those ports big enough to get the organ out. This is what it looks like in real life. Everything's all attached to the patient here. There's a bedside surgeon. I've already started.